All right, what's going on, guys? Got another video. We recently made a patient assessment flowchart, as you see on the screen right now. This is a zoomed out version of it, and I wanted to make a video to run through it. Okay, so if you will find this helpful, then awesome. I'm so glad. Many of our students do find it helpful. However, by looking at this, if you find it more confusing, then just feel free to skip this. Okay, so let's dive into it. As I pinch and zoom, we're going to get dispatched to a patient. When you arrive on the scene, you're going to see 6 things that we need to do. We're going to apply our BSI. We're going to ensure that the scene is safe, determine a mechanism of injury or nature of illness, and at this point, try to think about, is this respiratory in nature? Is this cardiac in nature? Neuro in nature? Immune in nature? OBGYN, GI, GU, any of those things. Those are natures of illnesses. And from your ambulance, how many patients do you see? And based on all these things, is there a fire? Is there an active assault situation? Do we need to escalate to ALS? This is a good opportunity to consider additional resources. As we leave our ambulance and enter the patient space, you're going to determine responsive or unresponsiveness. And if they were unresponsive, we're going to go down and check a pulse. If there's no pulse, we're going to be doing CPR at this point. If there is a pulse, then we're going to open the airway, see if it's open or obstructed. And if it's open, then consider positive pressure ventilation with the BVM. If we were to move back up and the rest of the EMT class is dependent on the patient who's typically responsive, you want to determine any life threats and chief complaints. And sometimes what you're dispatched to is different from the patient's actual chief complaints, so it's always important to re-ask that. You're going to determine the patient's description, so their age and sex at birth, and consider any trauma. And to be clear, a fall is not the only way someone gets hurt, so you want to ask the patient if they've experienced any trauma, and then consider any cervical spinal stabilization. Through your initial interaction with the patient, you want to establish how alert they are, if they are alert. If they're not alert, are they alert to verbal, alert to painful stimuli, or completely unresponsive? But if they are alert, what are the 4 questions we have to ask? Do you know where you are at? Do you know why we're here? Do you know who we are? Who the president is? Do you know where we're at? What day is it? So who, what, when, and where are the questions that we have to ask. And based on your visual cues, you have to make a determination on, is the patient sick or not sick? So think about, are they moaning, groaning, crying? Are they confused? What are their skin parameters? Do they look pale, diaphoretic? Any abnormal positioning, like tripod positioning, fetal position? And after this, now we are entering the patient assessment. And if I were to zoom out a little bit, you see that the 4 purple bubbles are inclusive and equal for the primary assessment. And to be honest, in real life, these 4 things are done simultaneously: checking for bleeding, checking for airway, any breathing, and circulation. Because we're in a classroom setting, it feels slow. This primary assessment feels slow, but I don't want you to miss out on any points. So if I were to zoom in, the first thing that we should be checking is assess and control for any exsanguination, any external bleeding. And then the next one is identify any airway obstruction. And the 3 orange bubbles below, snoring, gurgling, stridor, are some of the abnormal airway sounds that we might hear. And in the yellow, some of the interventions that we might perform with these respective abnormalities. So if the patient is talking, it is safe to assume that their airway is open or patent. And if we were to move on to breathing, the initial thing that we're asking for is for adequate tidal volume. Do they have adequate chest rise and fall? And if not, then I would highly consider positive pressure ventilation with the BVM. If so, let's move on down. Then you're going to assess the next 5 things: the relative rate, respiratory pattern, any accessory muscle use, what's their pulse ox, and then auscultate lung sounds. And then if you scroll to the bottom, you see various lung sounds that we might find: clear lung sounds, rales, crackles, wheezes, rhonchi, with the respective things that we might do for them, right? A lot of people get zoned in on that pulse ox, or immediately after hearing that the patient's short of breath, they want to like throw oxygen on right away. But we haven't assessed tidal volume. We haven't assessed relative rate, accessory muscle use, pulse ox, and the lung sounds. And these data points together help us make a determination on what treatment is most needed at this point. Is it a nasal cannula? Is it a non-rebreather? Is it a neb kit? Is it CPAP? For which CPAP, remember that we might need a blood pressure first. So keep that in mind, that it might not be the ideal moment to apply CPAP, okay? And at this point, you're going to identify whether or not the patient is in respiratory distress, failure, or arrest. And in this blue, I left a note for you stating that the main difference between respiratory distress and failure is the fact that the patient is altered mental status. And it's going to be bizarre the first time you see it, in the sense of the patient will complain of not being able to breathe. And you'll have EMTs, nurses, paramedics trying to help them breathe, trying to help apply oxygen to their face. And they're here ripping it off their face. And it's bizarre. But they are circling the drain. And what ALS can do in this instance is sedate them, paralyze their muscles, and attempt to intubate them. Whereas an EMTB will have to wait until they enter respiratory failure, completely stop breathing before they start managing their airway with a BVM and potentially an iGel, right? So at this point, let's initiate appropriate oxygen or ventilatory treatment, all right? Let's go on to the last part of our primary, the circulation. And as you see, there are 3 subcategories in blue under circulation. There's pulse, skin, and cap refill. And under pulse, there's 4 things. And if you can try to create a rhythm, a flow of the 4 things that you're asking within pulse: strength, relative rate, regularity, equality, right? And here are the potential options for them. So under the pulse strength, it can either be weak, strong, or bounding. Under pulse relative rate, slow, normal, or fast. Regularity, well, it's either regular or irregular. And with equality, you're comparing the left side to the right side, and there are certain conditions that can cause unequal pulses. Right? If you were to move on to skin, once again, try to get into a rhythm of looking for color, temperature, moisture. Right? And if it's hard for you to remember that, then think of some of the abnormal skin parameters like pale, cold, diaphoretic, or the normal skin parameters, pink, warm, and dry. Right? So there's pink is the color, warm is the temperature, and dry is the moisture. So some of the options that you might get under color: normal color, pale, cyanotic, flush. Under temperature, warm, hot, cool, cold. Under moisture, ashen, dry, moist, diaphoretic. And if we were to move on to cap refill, the only 2 options that we have for cap refill are when you press their finger beds or the palms, does the color return under 2 seconds, less than 2 seconds, or more than 2 seconds? It's pretty self-explanatory. And at this point, all arrows leading to this red area that says determine if the patient is in a state of shock. And it's a difficult concept to manage or grasp early on in the EMT class. However, the majority of different conditions of shock will produce pale, cold, diaphoretic skin conditions. And there are certain shock conditions like anaphylaxis or neurogenic shock that might produce alternative skin conditions. So keep the skin conditions in mind. And if the patient's in shock, we're going to initiate shock protocol, which includes applying oxygen, keeping the patient warm, and trying to lay them supine if they can tolerate it. Don't forget to consider environmental emergencies like hypo and hyperthermia. We're going to make a transport decision, and it's either load and go or stay and play. And to be honest, it's not like we're staying on the scene for a prolonged period of time. It's more so, it's a sense of urgency. And if anything was unstable in the ABCs, we have a heightened sense of urgency that we really want to continue our secondary assessment on the way to the hospital, right? So if we were to continue, we are now in the back of the ambulance. And if I were to zoom out, you see these 6 things all equal in line: OPQRST, sample, questions relevant to the chief complaint, and a physical focused assessment pertinent to the chief complaint as well, and then vital signs and diagnostics. And they're all equal to each other. You can do them in whatever order you want. But when we first introduce this in the class, we want you to stick to the script because we don't want you to miss out on any points. And in real life, you're going to have partners to help you out with this simultaneously. So if we were to start with OPQRST, a lot of students confuse the O and the T. So how we ask for onset is, did this issue come on suddenly or gradually? Provocation, palliation are two things. Does anything make it worse or better? Quality is asking the patient how to describe their current issue in their own terms. Region and radiation, can they localize where this issue is, and does it radiate anywhere? Severity is quantifying our issue. So on a scale of 1 to 10, 10 being the worst, how bad is it? And then time is the duration. How long has this issue been going on for? If we were to go on to sample, S is for signs and symptoms, and you would plug and play the relevant signs and symptoms dependent on the patient's chief complaint into this area. So, for example, if someone had a chief complaint of an allergic reaction, we would be looking for facial swelling, maybe oropharynx swelling, laryngopharynx swelling, peripheral edema, widespread hives like urticaria, itchiness, things like that, things that are relevant to the patient's chief complaint. A for allergies, M for medications, P for pertinent medical history, L for last oral intake, and E for events leading up to the chief complaint. And then if we were to go on next to that, we would ask questions that are relevant to the given scenario. Like in the case of allergic reaction again, has the patient been prescribed any new medication, tried any new foods, or maybe new cleaning products or laundry detergent? And then if we were to move on to the proper focused assessment, this would include a physical. So the physical is like, think of like look, listen, feel, and sometimes even smell. So you're looking for certain things, you're feeling for certain things. So in abdomen, you'd be feeling the abdomen for tenderness, rebound tenderness, guarding, rigidity, and pulsating masses. In neurology, you're smelling for unusual odors for like alcohol, or even fruity acetone odors for diabetic ketoacidosis. So look, listen, feel, and smell are all included in this physical focused assessment. And then vital signs and diagnostics are pretty simple. This is where we're going to obtain our blood pressure, heart rate, respiratory rate, pupils, and then our blood sugar and pulse ox. And it is everything together. You see all the arrows leading up to this point where we're going to provide a relevant intervention, things that we haven't already done so. So there are certain medications and interventions that we would already have applied in the primary, things like oxygen, maybe albuterol, epinephrine in the case of anaphylaxis. However, there are other medications like aspirin, nitroglycerin, CPAP, oral glucose, glucagon, Narcan, which have to wait until later down the line in the assessment before we administer it. And after that, we're going to do a reassessment. We're going to form a field impression, and then you're eventually going to give a radio report. And as we zoom back out, that was a lot, right, guys? I hope it helped. If it did, give it a thumbs up. If you have any suggestions, leave them in the comment section below. Otherwise, I will see you in the next one. Cheers.